speaker, Dr. YOKOI from Tokyo. So she's going to speak on red light therapy in controlling high myopia in Japanese children.
Hello everyone. Today I'd like to talk about red light therapy and its effectiveness on managing high myopia Japanese children. Repeated low-level red light therapy, or RLRL, was gained popularity worldwide for myopia control in childhood. Regarding mild to moderate myopia, randomized trials showed that use of RLRL therapy effectively controlled myopia progression and reached around 70% efficacy for controlling axial length or AL elongation and 76% spherical equivalent or SE progression. However, there are few reports on efficacy and safety of RLRL treatment with highly myopic children and teenagers. Purpose of this study 1 is to confirm the incidence and magnitude of RL shortening and myopic SE decrease after RLRL therapy in highly myopic children and teenagers in Japan. It was a single-center prospective single-arm study involving patients aged 8 to 18 years with high myopia. We investigated incidence rate of AL shortening and myopic SE decrease and also magnitude of AL shortening and myopic SE decrease. Here is the flow diagram. For the 30 participants, one developed photophobia on day 3 and ceased therapy, and 3 other subjects terminated the therapy because 12 months, 1 due to a lack of time commitment, and 2 due to a lack of motivation. In the end, 26 children completed the planned 12-month RLRL therapy period. The average age of the 30 participants was 11.6 years. 50% were male, and the average AL was 27.80 mm. After RLRL, the percentage of patients with AL shortening of more than 0.05 mm, 0.1 mm continued to increase for 6 months. Finally, incidence of AL shortening more than 0.05 mm reached almost 50%. In addition, after RLRL therapy, the percentage of patients with myopic SE decreased more than 0.025 diopter and 0.15 diopter continued to increase for 12 months. Finally, incidence of myopic SE decreased more than 0.25 diopter reached 43%. The magnitude of AL shortening was greatest at 6 months, with significant differences observed. After 6 months, some cases showed a gradual increase in AL, so significant differences was not seen after 12 months, but the shortening was still maintained. On the other hand, the magnitude of myopic SE decrease remained significantly over 12 months. Here is discussion. Regarding the magnitude of AL shortening, past reports shown in red plot indicate that for moderate myopia, it began to increase after 3rd month. The 12-month AL control rate is around 70% compared to single vision spectacles, and the incidence of AL shortening more than 0.05 mm is 21%. However, in our study targeting high myopia, as shown in orange plot, we found that the efficacy of RLRL was high and shortening persisted even at 12 months. The incidence rate of AL shortening more than 0.05 mm was 46%, which was almost double those with moderate myopia. Also, past report of moderate myopia, shown in red plot, indicates that myopia began to progress after 6 months, and the reduction in myopia of 0.25 diopter or more was observed in just under 20% of cases. However, in our study of high myopia shown in orange plot, we found that myopia continued to decrease over 12 months, and the reduction in myopia of 0.25 diopter or more was observed in 43% of cases. Here is conclusion of study 1. This study is completed a 12-month trial in highly myopic children and teenagers, and the first study completed in Japanese cohort. The incidence of AL shortening of RLRL in highly myopic children more than double those with moderate myopia. Our first study showed AL shortening after RLRL might be more pronounced in high myopia. Previous studies report that choroidal thickening has been observed following RLRL, with the extent of thickening linked to the effectiveness in controlling myopia. Therefore, the observed AL shortening could be due to choroidal thickening. However, previous studies have confirmed significant choroidal thickening, but this could only account for 28% of AL shortening. The second study aimed to investigate the mechanism of AL shortening after RLRL using ocular biometrics and image analysis in highly myopic children. Image analysis was conducted using sweat source OCT. We captured radial scan images at the beginning and 1 year later and compared them. Also, we evaluated the colloidal changes in each of the 9 grids of ETDRS and measured macular thickness and foveal thickness. The average age of the 26 participants was 11.2 years, with 54% being male. After a year of RLRL, there was a significant increase in refraction and increase in macular and foveal colloidal thickness. Surprisingly, around 20% of cases show a change in inner scleral curvature. The macular colloidal thickness in myopic eyes known to be thinnest on the nasal side and thickest on the temporal side. This pattern was also observed at baseline. After 1 month of RLRL, colloidal thickening was observed in all 9 regions, with no significant differences in the rate or pattern of colloidal thickening among these regions during 12 months. Next, I'd like to show 2 representative cases with a change of scleral shape. Here is an 8-year boy who experienced a 0.3 mm shortening in AL. After 1 year treatment, horizontal OCT showed the temporal inner sclera shifted outward and the nasal inner sclera shifted inward, which was resulted in a flattening of the curved inner sclera. This change was also flattened the RPE line. Here is an overlay image of the horizontal SSOCT before and after treatment. Blue OCT image shows pre-treatment. As shown by arrowhead, the curved retinal border was flattened after treatment. Funda's photography indicated a slight improvement in the treated optic disc. The inner scleral flattening was not obvious in vertical OCT scans. Here is another case of a 9-year-old boy who experienced a 0.3 mm shortening in AL. Overlay image of horizontal SSOCT before and after treatment. Blue OCT image shows pre-treatment. As shown by the arrowheads, the retinal border is elevated on the nasal side of the fovea and descend on the temporal side, resulting in an overall flattened retina. The multiple regression analysis showed that the macular colloidal thickening and change in inner scleral curvature were associated with the AL shortening. Here is the discussion. So far, no study was assessed the change in scleral shape after RLRL, but we did observe a shift in 90% of cases. Only 29% of observed AL shortening could be explained by colloidal thickening. Therefore, we thought AL shortening may result from both an increase in colloidal thickness and a change in sclera. Since the deformation of the sclera is more profound in high myopia than in moderate myopia, the sclera shape can flatten more, causing a greater shortening of AL. The exact mechanism of the scleral flattening was not determined. Previous studies show that scleral hypoxia contributes to myopia development by causing remodeling of the extracellular matrix, resulting in decreased scleral strength and thickness. Meanwhile, RLRL increases colloidal blood flow, thus increased colloidal blood flow by RLRL not only thickens the colloid but also improves scleral oxygenation, inducing change in scleral structure and shape. Here is the conclusion. Colloidal thickening was observed to be associated with a degree of AL shortening. The scleral curvature is flattened in some cases, which is possibly correlated with the changes in the colloid thickness and AL. It would be interesting to determine whether the observed scleral flattening is long-lasting. Thank you.